been speaking about mental health since before it was cool. 28 years of being a psychiatrist. What have you learned about human society?
Please take ownership of what you say to people who have mental illness. It is not a matter of choice. It's a medical illness.
What's the bare minimum situation in a human being's life for them to think that, okay, I need to go for some kind of therapy?
Imagine sadness 24/7 without even an apparent reason. How tough would that be?
The problem in today's day and age is that lots and lots of people are self-diagnosing without even a visit to a psychologist or a psychiatrist.
I get very upset when I see that. You will hear all kinds of things that people will come and say. That's nonsense.
With adult ADHD, how does it impair the nature of your life?
You may struggle in your relationships.
Why? Is there like very significant childhood experience that affects a lot of adults in urban environments today?
Experience of in childhood can lead to significant mental health issues as adults.
The thing is, the teenagers of today have grown up in a world that's fueled by social media. The most common problem you hear about is anxiety.
There is a 25% increase in depression and anxiety. I feel very bad for this generation.
Cannabis usage has increased a lot.
Just because something can also have a medicinal usage does not make its non-medicinal usage cool. It makes it stupid.
It's probably more popular than alcohol today.
If I go back into the past, would I have thought in 25 years down the lane I will have as many young people coming with cannabis? Not in my worst nightmare.
Dr. Samir Parikh is one of the most respected psychiatrists in our country. We've done a bunch of health-related episodes with doctors, with health and lifestyle professionals, lots of life coaches, but this is the first time we're bringing on a psychiatrist on the show. We've had a very senior psychologist, Dr. Havovi Hyderabadwala, on the show earlier. But the process of clinical psychology is all about changing your thought patterns in order to achieve a new phase of your own life. Psychiatry is where medicines are involved in the process. A little bit of more biological incline is involved in the process. And that's the aspects we tried breaking down with Dr. Samir Parikh. If you enjoy any kind of talk related to psychology or mental health or hacking the human brain, this is the episode for you. It's Dr. Samir Parikh on TRS. Welcome to TRS, Dr. Samir Parikh. I think there's very few people who've spoken about mental health for the amount of time that you've spoken about it. You've been speaking about mental health since before it was cool. I think it's become very cool to speak about mental health nowadays, especially in urban India. But mental health is pretty much your life. Fair to say?
Mental health is my life. And it started, I think, probably before you were born.
Yeah.
So, yeah.
What's the difference between a psychiatrist and a psychologist?
Simple difference. I'm a medical expert. So how you go to your neurologist or cardiologist who've done their MBBS and their specialization, so that's your psychiatrist. So we prescribe medications.
A psychologist is not allowed to prescribe medication.
They're not medical experts. So they would understand the science of psychology. So they would be doing more of your talk therapy. So the counseling, psychotherapy, interventions. So that part is by the psychologists, and the medical aspects, which is diagnosis, medications, that's a psychiatrist.
Do you work together as a team?
Yeah. If you don't, it'll be incomplete. I mean, let's accept it very, very clearly. In fact, when people come and ask me that, should we go to a psychiatrist or should we go to a psychologist? My answer is very simple. You go to someone where there is access to both. Otherwise, it will not be complete treatment.
But not everyone has to go to a psychiatrist.
And vice versa.
Okay, so now I'm not talking about extreme mental health issues in this question, but what's the bare minimum situation in a human being's life for them to think that, okay, I need to go for some kind of therapy, either a psychologist or a psychiatrist?
So let's put this in a spectrum, Ranveer. Try and understand this. Aise dekho, that start from a spectrum where you have everyday hassles, a bit here and there. Typically, you should be able to deal with it by yourselves. You should have been given enough skills. You've learned how to cope up with life. You have some strengths, some weaknesses, support system. Then you are struggling with some things. You talk to someone. It could be your best friend. It could be a colleague. It could be a family member. Move forward, you might start having some concerns. Now, the moment we talk about, let's say, a mental ailment, rather than looking at the diagnosis, you look at the functional impairment.
Functional impairment.
Functional impairment.
How does your daily life get affected?
Correct. So, for example, let's say you come and say that, I'm feeling low today and I'm feeling sad. Not just because you are feeling low today or sad today, that does not mean you have depression. Problem is that in the English language, low mood can be called as depression. So you may, as a matter of fact, be talking and saying, I was feeling low and depressed today. But when you say low and depressed, and when I say depression, there is a difference. For me, depression is a medical illness. For you, you are expressing a certain emotional experience that you are having today. Right? So, functional impairment, which means these symptoms or these distress that I'm having, they are persistent, one, for a period in time. Let's say bare minimum 2 weeks.
2 weeks.
Bare minimum. So it can't be that I had a bad day in the morning, I'm feeling low and I think it's depression, but I'm fine by tomorrow. No, that's not depression. That's a normal mood. You will feel angry, you will feel anxious, you will feel restless, you will feel irritable, you will feel happy and cheerful, which is fine. Then, besides the duration, which is the pervasive component, it's sustaining. It's now causing impairment. Now, impairment, what will happen is, your work impairment, if you're a student, it would affect your academics. If you are working, it would affect the quality of your work. Your social impairment, which is an impact on your relationships. Yourself, as in psychological impairment, which is in terms of how you feel, how you think for your own self. So when any of this starts impairing functionality over, let's say, a 2-week period, then probably it could be an illness as well. My suggestion has always been we need to strengthen the general physician, family physician route. There is no substitute for that in our country. You go and talk to your family physician. Your family physician is capable of telling you that, hey, nothing, lifestyle, thought process change, behavioral change, maybe a medical intervention, no go to a psychologist, no see a psychiatrist, any of that. And what that will do is, you'll again have layers that because you have less number of experts, people who need help will be given help at the earliest.
I definitely want to talk about lifestyle factors over the course of this podcast, but let's unpack anxiety first. What is anxiety, and do you as a psychiatrist view it differently than a psychologist, or are you all talking about the same thing? Additional question, what is the biological aspect of anxiety?
So let's try and understand a very broad understanding of mental illness. Okay? Biological factors, psychological factors, social factors.
Sure.
Very, very basic. Biology, not in your and my control. So if I have thyroid, my body is not secreting enough thyroxine.
But can lifestyle factors alter this?
Could I have prevented my thyroid by lifestyle factors? Probably not. I mean, again, I'm not an expert in this. Probably a colleague from endocrine would be able to answer that question better. But would my lifestyle have an impact on, let's say, my asthma? Yes. I've been told to do my lung exercises regularly. I don't. Just don't tell my doctor. Right? But that's a fact. So if I don't do that, what is that doing? It's making my existing problem more. I'm more prone to relapses. So let's say if I am having any medical illness, including a mental illness, of course my lifestyle is going to have an impact. But to say that my lifestyle can prevent, or to say that if I were a positive thinker, the most cliche thing that you'll hear, be a positive thinker, it'll all be okay. But my illness brings a thinking which is opposite of positive thinking biologically. How do I do that?
Because thoughts are also outcomes of your hormonal
neurotransmitters. So biological is my genetics, my neuronal pathways, my neurotransmitters, that whole chemical locha thing. It's real.
Can you go deeper into this?
Yeah. So that chemical aspect is real. So for example, let's understand it like this. If let's say someone has depression, so serotonin, I'm just taking the example of one neurotransmitter. It's more common understanding people have about it, so I'm using that. Serotonin is low, which means because of certain aspects, serotonin supply in my brain that is required is not happening.
You mean the average person has a certain amount of serotonin in their brain, which is not happening in this depressed person?
Correct.
Okay.
A very basic understanding I'm giving you. So now, like how I have thyroid, or let's say a friend has diabetes, so that body is not making enough insulin, my body is not making enough thyroxine, somebody else's body is not making enough serotonin, you will have to get that serotonin back. As simple as that.
How common is this in human society?
I'll ask you a question.
Sure.
I'll give you 2 buckets. One bucket, I'll put depression and anxiety. Other bucket, I'll put cancer, diabetes, chronic lung disease, COPD. Can you tell me which one you think would have more cost, let's say economic or overall cost to the society? Which one of these?
To society?
I mean overall.
You mean to say that...
the cost implications between these two.
Probably that one? This one?
They expect that by 2030, $6 trillion.
Okay.
In a year.
You're saying that this lack of serotonin situation...
As in anxiety and depression as an illness, that is the impact of just these. This is the impact. And look at where our focus is. Look at healthcare providers around you. Look at the big hospital networks around you. Look at all the conversations of health. We are not focusing enough on mental illness and mental health. That is a fact. We are neither focusing on it, nor is the intent there, nor is the investment there. But what is there is random chatter. And the chatter can range from
अरे ये तो कुछ नहीं है.
Facts to complete rubbish. And more importantly, advice which is absolute nonsense. So coming back to what you were saying, serotonin is low. So that's biology. Now, the other component, so biopsychosocial I had said, the psychological component is my thinking, cognition, my behavioral patterns, my emotional aspects. Now, this is something that has become who I am over a span of time. So many vectors have acted on me. Early schooling, parenting, upbringing, this experience, that experience, on a backdrop of my neurotransmitters which are there in my body, and then my social factors, which is my environment. All of these are playing a part in it.
Your life story.
Yes. And now, look at the treatment. Let's say if I have depression or anxiety, I'm going to use medications. If I have moderate to severe, in mild I might not need the meds. Through meds, I'm correcting the biological component. Time and again, I'm going to say this, and for everybody listening, please respectfully take ownership of what you say to people who have mental illness. It is not a matter of choice. It is not their fault. It is not their circumstances. It's a medical illness. You don't blame somebody for having a lung disease. You don't blame somebody for having you don't blame somebody for having a thyroid illness or a typhoid. So you don't blame somebody and say it's your fault you had depression. That's nonsense. It's insensitive, inhuman, violating the rights of individuals.
I think the problem that the average urban Indian adult at least is having is that too many young kids are self-diagnosing.
Yes.
That's the counter argument to I understand what you're saying. What you're saying is from the perspective that for decades it's been kind of brushed off. That there's no such thing as mental health. Why do you want to go to a psychiatrist? Have you gone crazy? You're coming from that angle, and we'll address all of that. That's a very important conversation. I also believe at this point that's more important as a conversation in Hindi rather than English, because people in urban centers have understood the significance of mental health. But parallelly in tier 2, tier 3 and the regional language speaking belts, people have just begun to understand it. Unfortunately, after the demise of Sushant Singh Rajput, that's what set it off. And the whole... But coming back to this urban center conversation, sir, the problem in today's day and age, at least from our eyes, is that lots and lots of people are self-diagnosing without even a visit to a psychologist or a psychiatrist.
So this self-diagnose aspect is not only limited to very young people, first of all. Anybody who is using a search engine is coming to us with some kind of a self-diagnosis. In my branch, not just with self-diagnosis, more importantly with a whole list of views about medications and treatment. And you will hear all kinds of things that will come. People will come and say. You will still have people coming and saying that I think going to a therapist will make them dependent to the therapist. Matlab, it's just not going to happen.
I think the base level statement here is that don't self-diagnose as much as possible.
And you will still, I mean, no matter what I say, you will still read. So I come from that place now that my default is expecting and accepting that certain things will happen. So I'm very chilled about it now. Okay. So, but yes, people are self-diagnosing. They keep coming with newer and newer terms every few days, which were not in medical textbooks, but now they keep finding their place, and everybody thinks that everybody around is having some kind of a problem.
The most common problem you hear about is anxiety.
Yes.
Now I remember being 13 or 14 without social media, and then I remember social media coming in, changing the way you thought. The thing is, the teenagers of today have grown up in a world that's fueled by social media. Anxiety is much more common. We see suicide rates going up all over the world. Something has gone wrong with society, and I feel bad for this generation as well. Now we put forward that base level statement of don't self-diagnose, go to a psychiatrist, go to a psychologist. But sir, as a psychiatrist, what do you look for to confirm whether someone has anxiety?
See, as of now, you're looking at most mental illnesses as clinical diagnosis, right? So which would mean that when you'll talk to me, you'll tell me what you're experiencing. I'll look at the symptoms. I'll probably ask you some questions to understand what your symptoms are. I'll try and understand the duration, and I'll try and understand the impact on your life. These are two things which are very important.
Duration
so
and impact on your life.
Okay. So duration can't be just yesterday or today. And it can't be once a year for 15 minutes. It has to have an impact.
2 weeks is your number usually?
At least when it comes to depression. I mean, different illnesses will be different.
Sure.
Right? The other part, when you mentioned also about the... So WHO 2022 report very clearly says that there is a 25% increase in depression and anxiety post. So that's an established fact. Obviously, multiple factors, and we'll probably have another decade or two to understand what impact was biological, what was the psychosocial aspect. But as of now, where we stand, that is what it is. Now, anxiety by itself is a symptom. I am anxious. But anxiety disorders is a spectrum.
Okay. One level lower. Yes. What is anxiety?
Worry, apprehension, feeling that of something happening, a doom, a fear kind of a feeling, thought process.
Pre-exam feelings?
Yes.
That's anxiety?
Yes. And physiologically or in body experiencing certain things.
Short breath?
Yes.
And?
Palpitations, perspiration, maybe a bit of nausea, maybe a bit of tremulousness. Now, anxiety disorders, it could be a panic disorder, which means I have repeated panic attacks.
What is a panic attack?
Sudden episode lasting for a few minutes where I feel that something's happening to me. These individuals end up visiting emergency, end up visiting cardiac doctors a lot more because it feels as though you're having a cardiac or you are dying or something's happening to you. So they keep rushing there because they feel you can't breathe, something's happening, I'm having palpitations, I am feeling like choking happening. So these panic attacks happening. And you diagnose, people say there's nothing, but it becomes a pattern. Then you become scared. You don't feel like going out. You don't feel like meeting people. You are scared of what happens during the next episode or next attack happens. Starts playing on your mind. So that's panic disorder. You also have phobias. For example, social phobia would be that I'm hesitant in, let's say, in a Viva exam. I'm absolutely fine in a written exam, but the moment I have to speak in front of an audience or a supervisor or an examiner, or as a working adult making a presentation or meeting clients, that's where I start struggling. So I have the same panicky symptoms in that situation.
Okay, small rewind. What is the feeling-based difference between a heart attack and a panic attack?
So try and understand like this. For me to say how would you know what is an impending heart attack or what are symptoms, not my specialty, shouldn't even say that. But what I can tell you is how a panic attack feels. Sure. Panic attack feels, so it's like a inverted U graph. Okay? So you feel something building up, gradually increasing. You may have variety of symptoms, from headache to dizziness, to giddiness, to breathlessness, dry mouth, watery eyes, sense of choking, dry tongue, palpitations, butterfly in the chest, tremulousness, frequently wanting to go to urinate, feeling you can't be steady on your feet, feeling that something's happening to me, something will happen to me, am I dying? Those kind of experiences an individual has, peaks about 15-45 odd minutes plus minus, and gradually starts going. Now, because I don't know why it happened, because I've not been aware that this could be an illness by itself, a well-defined illness with an easy treatment, I feel, oh God, what's happening to me? The moment I feel what's happening to me, I obviously start seeking help. So I go through checkups, but those checkups are not checking for where the problem is. So obviously, I'll probably come clean in my blood profile, I'll come clean in my cardiac profile, so on and so forth. And yet that episode comes. So now I start fearing that when will the next episode happen? Where would it happen? Sometimes I correlate places. Sometimes I correlate situations. Sometimes I correlate something else. That correlation becomes another pattern of anxiety for me, which is where a psychologist will tell you to disconnect. These two are not related. You are relating them. Go ahead and gradually face it.
Like, for example?
For example, let's say you got a panic attack when you were about to board a flight. Now you're anticipating the next time you're about to board a flight. Then that anticipation becomes so much that one day prior to boarding the flight, you're probably not able to sleep too well. Then a couple of days before you start worrying about it, then you start avoiding these flights as much as you can. And then it starts affecting your work because flight was probably an important aspect of your work.
What's the medical treatment here?
So biopsychosocial, you look at medications for anxiety disorders. You will also look at cognitive behavioral therapy, some other forms of psychotherapy, which is your counseling and which is done by
you're trying
psychologists.
To shift thinking patterns.
Yes.
In cognitive therapy.
Yes, in cognition. So for example, something bad always happens to me. So the correction would be always is not possible. When bad happens, good also happens. Why don't you start filtering the good and the bad, and you'll stop seeing it as all or none or a generalization or a maximizing, minimizing, and so on and so forth. And then you bring some changes in your lifestyle. For example, if let's say how much caffeine you take, have you noticed that maybe caffeine intake increases your anxiety, right? Or let's say substance use. Have you noticed that when you take certain substances, you have more anxiety happening? I mean, there is evidence that let's say people who would use alcohol more regularly statistically have a more correlation with depression and anxiety as an illness, whereas people telling each other in in social gatherings would be that I feel relaxed when I drink. You may feel relaxed when you drink at that moment, but if you are a regular user, then you are also more prone into having anxiety and depression as an illness.
Like you pay a price for that feeling of chill.
Yes.
That's the truth about intoxication. And I've gone through multiple phases of intoxication in my college life and a little bit after college life. I've been a teetotaler for a long time now. And this is the nicest I've felt in my life. But I remember what intoxication felt like. It felt great while you're intoxicated, but you'd pay a price. That's what people don't understand.
You pay a huge price. You will not be able to find a longitudinal axis of success if you're on substances. Anybody who tells you otherwise is absolute nonsense.
Okay. Speaking about this, mental health being a universal human right, the one thing that all human beings share is their own human biology to a large degree, right?
Yes.
Everyone has a nervous system, everyone has a brain, everyone has a spinal cord, everyone has a set of the same types of hormones and then different levels of the hormone. I know this is a very weird question, but how would you biologically categorize mental health? What I mean by that is, I'll try doing it and then you add to it. So, mental health is affected. So, let's take the case of bad mental health. Okay? Someone who's going through a mental health issue. It's affected because of the difference in your level of hormones as compared to a normal so-called happy person. As in if, like you mentioned how serotonin can be low. That's one aspect. Secondly, those thought patterns that you spoke about, cognitive therapy. On some biological level, it's related to neuroplasticity. Correct? Like as you move forward in life, your brain structure keeps changing. Now, if you've thought sad thoughts constantly, if you're exposed to sad circumstances, you will develop a so-called sad part of your brain more deeply. Please correct me. The third one I would probably encapsulate into mental health is, other than hormones and your brain structure, is something related to your nervous system. Now, I'm not a doctor, so I'm not able to expand that thought more. But perhaps your nervous system is more, it can be triggered more easily. Again, I'm trying to look at the neurological side of this.
Yeah. So, ideally speaking, bad mental health per se may not be the best terminology, right? You look at mental health and you look at mental illness. Now, let's look at, and I'll come to what is mental health and mental illness. So, when you look at this whole aspect of brain structures and all, you are increasingly touching the neurological processes, neurological aspects as well, right? When I'm talking about the mind, when I'm talking about mental health, there are also components which are outside the body also, which basically means you and I may have everything same, all neurotransmitters are fine, all other things are fine, but maybe our experiences were so different. Or let's say I may have experienced a trauma. I was living in a conflict situation, for example. Let's say I was born in a conflict zone. I was born during war. So imagine the thresholds of violence, sound, trauma that I have experienced. So my arousal systems, my reactability, my impulses would have an impact. So one needs to understand, and I keep coming back to the biopsychosocial. To understand mental illness, you will need to understand biopsychosocial. Only biological is not the way to understand it. Because the moment we do that, then we are over-biologizing this in a way.
That's exactly what I wanted to ask.
And the moment we do that, that means we're almost saying only medications as a solution, which is also not true.
It's not just about the hardware, it's about the software as well.
Yes, and it's about your approach as well. At the same time, when I say your approach, I'm not saying you can solve it. But I am saying based on the illness that you have, you may have a role to play in the latter part of your treatment as well, for which also you will get the right kind of guidance and support. And if support comes from your family and friends, perfect. And I give an example of impact, let's say, of would have been different. Let's say, look at two people. Same age, same background, same education, same finances, same everything. Both have at the peak of but one has enough support systems available who were able to support this person for those 7 to 8 day period. And now look at this individual who did not have any support system at that time available for whatever reasons. Obviously, the psychosocial impact would be different, right? Goes without saying. At the same time, there might have been a biological impact also happening, but the psychosocial aspect needs to be seen. So we must understand this aspect and not necessarily over-biologize this. That's why when you look at some of these aspects of neuroplasticity, for example, you also need to understand that there is also evidence that, let's say, if somebody had mild depression and that person was given certain standardized form of psychotherapy, then that person also recovered, which means there is something which would be happening inside me through that therapeutic aspect as well. Psychotherapy, counseling is not two friends talking. In fact, if you meet your therapist in a coffee shop, then you should kind of run away from your therapist, because your therapist should be in a structured environment like this.
Let's speak about weed, because cannabis usage has increased a lot.
Yes.
Not just in India, but because it's legalized in America, it is starting to get legalized in Europe as well. The thing is, so there's something called a usage versus dependence scale, I think, okay, which is the usual argument from the cannabis side. And again, this is not a pro-cannabis or anti-cannabis conversation. I'm just detaching myself and talking about this because this is a podcast based on culture. And it is important to talk about weed because for parents watching this, your children are doing it, their friends are doing it. It's probably, at least in Mumbai, Delhi, Bangalore, Kolkata, Chennai, more popular than alcohol today. I see people, kids especially, not drinking, but smoking pot. And you see this with people in their 20s, you see this with people my age as well. So many of my friends don't drink anymore, don't smoke cigarettes, but they consume a lot of weed or hash, which is basically cannabis, like THC. How many cannabis related situations do you see every year? And has the percentage increased since 1996 when you began your work as a psychiatrist? Or was it just the same?
Yes, I see more cannabis-induced illnesses than you can imagine.
Cannabis-induced illnesses?
Yes, absolutely, undoubtedly. Right, which means you know past history of a mental illness, you use cannabis, sometimes also single use. Anybody who tells anyone that an occasional use is fine is not correct.
Like what happens in that single use?
It could be, I mean, you could have an anxiety episode, the panic attack that I talked about. You may have
which is called BT, bad trip.
Yes, you can call it whatever you want to call it, but if you actually need to take a bad trip to have an experience, then just live life, right? Life will give you good and bad trips both.
Do you see more alcohol related situations or more cannabis related situations?
Difficult to put that together. The reality would be that if you're using one, the odds are that you will end up using the other soon enough. And that's how it is. So people whom I'll end up seeing would be people who'll start with one thing, then they add the other, and then probably add a third one, and so on and so forth. And just because anything can also have a medicinal usage does not make its non-medicinal usage cool. It makes it stupid.
Yeah.
So if you take a paracetamol for fever, you take it because you have fever. You don't take a 1/100th of paracetamol and think it's going to do something just because you wanted to do something and just because you've heard about it or somebody has told you. In a longitudinal axis of life, if you are a regular user of cannabis, you are not likely to maintain a high level of functionality. Yeah. That is not going to happen.
Okay, I'll give you two perspectives here. It's adding to what you're saying. Okay, I'm 31 now. All my friends have smoked a lot of weed in their life. I'm at a stage in life where now we're thinking of family, etc. I stopped my cannabis usage long ago. what I noticed was you become way sharper. Basically, you become faster in your thought. All my friends who are leaving it at this stage say the same thing. Many of them want to leave it but are not able to at this stage because of years of doing it. I have friends who've been doing it every day for years now, and you can see it becoming an issue related to anxiety now. You can see it affecting careers now at this stage. This is such a controversial thing for me to say as well, but this is the truth of urban Indian society. It's there around us and it's celebrated. I also parallelly have seen people who drink once a month, who smoke pot once a month, and they're fine. They're functioning okay as professionals, and that's their counter to anti-cannabis conversation. But I do believe it's important to at least speak, especially for a psychiatrist, to speak publicly about cannabis, just so that people understand the mental health outcomes of cannabis usage. Because it's not as rosy as California paints it.
There's nothing rosy about it. No matter how much you paint it rosy, it's not going to be rosy. If I go back into the past, would I have thought in towards the end 1990s when I was finishing my psychiatry education that 25 years down the lane I will have as many young people coming with cannabis? Not in my worst nightmare.
Why do they come to you specifically? To get rid of it? Like, I want to leave, I want to get de-addicted.
I mean, so sometimes it will be because you're having a certain problem and we realize that cannabis is playing a significant part in it, right?
They don't realize it themselves.
May or may not. Sometimes they want to quit and are not able to. It's like this. At the end of the day, a substance of use is a substance of use. It, like any other substance, will give you tolerance, it will give you withdrawal. Anything that gives you tolerance and withdrawal, stay away from it. There is so much in the world to do. I mean, come on. Don't tell me that you want a high in your life and you need a pot for it. Come on, spend some quality time with your friends. And you'll hear this, that, I have it only with my friends. They may not be your friends then.
Yeah.
Because if you need pot to tolerate them, then they may not really be your friends.
A friendship that's based on a substance always dies when the substance is taken out of that equation.
Yeah, it's not a friendship. It's just...
The thing is, you don't understand this while you're in college. Friend groups are built out of cannabis usage. In every engineering college, I'm sure in every medical college as well.
I hope not. Not in my time, and I hope not. I want to be blind about this.
My two crutches for leaving alcohol, first, alcohol was career. That, listen, need to step up. Cannabis was sport. I realized, this thing called this weekly game of football can change the look of my body. I'm an on-screen personality. I need to stay fit. Cannabis was coming in the way of football. Use sports to climb out of it. Once you're fully out, once you're distant from your usage, you realize, oh damn, that's what it was doing to my body and mind. But you don't realize it even if you're listening to podcasts like this.
That is the only thing which is important. Which means when a young person like you says that a younger version of you made the same, let's say, mistake and was in the same cycle of misinformation and experimentation, as it is said, and when you are not a user, see the impact on you. You realize that. Yeah. If you realize that, now do you realize that you are being outnumbered by those who were not able to quit? And if when you were in your 20s, if the number was X, it's now X multiplied by something. And another decade, it will be X multiplied by something else. I'll be long gone. What? Decade here, decade there. But we are not realizing that a 10-year-old will be a 20-year-old tomorrow. And if we create this narrative that we are creating about substances right now, it's not cool. It's just stupid.
Yeah. I think this is a very good point in the podcast to talk about dopamine in detail. It's something that people want to learn more about and something that people have a morphed understanding of. Okay, so from a psychiatrist, sir, can you explain dopamine from the very most basic level up till like neurological disorders related to?
So try and understand it like this. Body has chemicals. Let's say one chemical is dopamine. when you are feeling nice, something exciting is happening, bit of dopamine is released.
When you feel good about life.
Yes, why not? Right? Now let's say when you take weed, and it gives, let's say, a surge of this dopamine in its last, whatever it does, pathways and all, eventually surge of dopamine. Okay? We hold this thought here. Now let's shift this to what happens in psychosis. Let's say schizophrenia. Schizophrenia is an illness where the same dopamine is at a much higher level, which is why it is giving you symptoms of psychosis.
What happens in schizophrenia? Because
so delusions, hallucinations, as in your thought imbalance happens, perceptual imbalance happens. Now, medicines which are used to treat psychosis, including schizophrenia, are medicines which lower the level of dopamine. So, antipsychotics, the word antipsychotics. Psychosis, antipsychotics are medicines which lower dopamine. Very basic example I'm trying to help you understand. What I'm trying to say here is dopamine is correlated with psychosis. We need to understand this. This is one part. So obviously something which increases suddenly in my brain because of an external stimulus and something which had happened by itself gives me an illness, there is a concern. There should be a concern.
You're saying the two things are linked.
In a way that as a clinician, I see single usage of cannabis or people who've had recent cannabis coming to me with, let's say, a psychotic episode also. Irritability, agitation, not being able to sleep, lots of thoughts which are racing, fearfulness, paranoid related fearfulness, that may happen. Or people who experience lots of fear, anxiety reactions, they come to us. Other part is, there is also research on which is going towards the fact showing that long-term users of cannabis have very similar brain chemical and brain structure that is seen also in schizophrenia. There is also evidence that early users of cannabis and episodes of schizophrenia, or let's say the start of schizophrenia, there is a bit of correlation also. The reason I'm putting this in this manner, of course, does not mean that each cannabis user and schizophrenia is related. That's not the point here. The reason why I am choosing this particular explanation is because the opposite is sold to young people. You'll feel good. Yes, you will feel good for a moment. But that feel good may also not just be a spike. It may be an explosion, which may be not good for you. And there is no way for you to know whether it will be a surge of relaxation or happiness or whatever, or joy, or an outburst of a clinical problem. There is no way you can know that. What we know is that some individuals may reach the clinical spectrum also. Second aspect, that regular long-term users, something that I have said very clearly, how many people would you be able to see on a longitudinal axis to be regular users and continue to maintain the best level of their functionality, especially the neurocognitive aspect? That's something to think about. Slowness, amotivation, all of those aspects. So let's not look at substances with random anecdotal and personal experiences. Don't say or don't allow somebody to tell you. You may hear this for, in our times people would say this for cigarettes, right? That, oh, I know so and so who smokes X number of cigarettes a day, they didn't get anything. But that doesn't matter. If X percentage of people are going to have physical, or let's say a lung problem, or a lung as in a respiratory problem because of cigarettes, and if that percentage is significant, then I have to look at that component, not the occasional couple of here and there who will not have anything. That's not how it works.
Can you explain ADHD from a medical perspective?
Attention deficit hyperactivity disorder. It's one of the most common childhood psychiatry disorders that is there.
What happens when you're diagnosing someone, when you're trying to figure?
So attention deficit hyperactivity. Let's look at these two components. Attention deficit, simple meaning, I am not able to sustain my attention on a particular stimulus for a significant period in time, causing impairment in my functioning. Simply, so if I am, let's say, attending a classroom, I don't even realize when my concentration goes from the teacher and it goes outside the window, and I'm daydreaming, or I'm lost in my thoughts, or I am reading a paper, a question paper, and I do not notice question number 2 and I go on 3, or I leave something incomplete. I didn't realize I've not added the last line or 2 and I move forward. So my attention span is less. So I'm not able to finish one particular task. So I will be forgetting things. I will be having incomplete work. I'll be making more careless mistakes, as they are called. And that's why I said if somebody makes more mistakes, look at why, rather than just using a word careless mistake, so on and so forth. So attention aspect. Then the hyperactivity aspect. Hyperactivity and impulsivity together.
You know, a lot of people self-diagnose themselves with ADHD and use all these things as excuses to let go of responsibilities. That, oh yeah, I have ADHD, that's why I forgot. Oh, I have ADHD, that's why I can't listen to you well. It's not like that.
So I have, my opinion is very simple on this. Using mental illnesses both as slurs or as explanation of behavior is, I think, unfortunate, and it's a violation of empathy and human rights.
Self-diagnosis is an infection.
Yes, self-diagnose is very, very infectious in its own way, because it is also something that we copy from each other, but more importantly, it's an infection that is given to us by our phone because of the sheer access.
How do you, as a medical professional, diagnose ADHD?
Again, you'll have to look at, understand this very simply, and not just for specific illnesses. Let's understand for mental illness per se.
Sure.
You are looking at a durational change, which means pervasive, consistent pattern of symptoms. Then symptom category, which would based on the illness, but otherwise symptoms can be either on your mood, sadness, anger, outbursts. It can be on your thoughts, positive thinking, negative thinking, thinking things which are not right. I had mentioned delusions earlier. Then you look at the behavioral component. You look at the social component, the relationship aspect. You look at your basic aspects of day-to-day living, which would be sleep, appetite, weight, right? So if you feel that there is an imbalance or a change happening in any of these categories consistently, causing impairment in your functionality, that's how the illness is an illness. Certain illnesses also have some standardized tests available. Those tests are done typically by clinical psychologists, and they are tests. Not all people need tests. Not all people need questionnaires. Some of these questionnaires are used at times to map the treatment, recovery, to understand the baseline. A lot of times they may not be needed. So one needs to look at, and it's also about severity, which means the level of functional impairment. That is severity. It means if it's mild, I will probably not give you medication, and we'll probably look at what aspects of cognitive, behavioral, the neurocognitive retraining component, that can be done. If you have moderate to severe, I may decide to also use medications. If you have severe, I'll probably definitely give you medication, unless there is something other which, because of which reason I'm not able to give, a comorbidity or a medical problem, that I may decide not to give it.
With adult ADHD especially, how does it impair the nature of your life if it's actually ADHD?
So it'll affect the quality of your work for sure.
You won't be able to perform professionally.
Yes. You'll be performing below par or below your ability at a consistent level, and or you will also take a lot more time and energy to be able to function at the level which is expected as compared to others. You may struggle in your relationships because of ADHD as well.
Why?
Because of multiple reasons. The attention deficit component affecting your communication, at times the hyperactive impulsive component bringing out more outbursts, that may also happen, and both of them could happen. And you're always so under pressure and drained, both because the basic aspects of life that you need to be doing and you are doing are taking so much out of you.
It's tiring.
Yes, it's extremely tiring.
Physically and mentally tiring.
Yes, it is. It is tiring, and that's the unseen and the silent component of mental illnesses per se. You see fever, you measure it. You see pain, you get it. You see a swelling, you understand. But most people who have a mental ailment, you don't see it, so you just end up giving them gyan that, go run, go jog, go do this, do that. It's not. That's a problem. Millions of people struggle in silence across the globe because of the stigma, because of the stereotypy. Millions.
Okay. Another generalized question. 27 or 28 years of practice, I think you finished. 28.
Yeah.
Maths. But simple question for you. And I'm not asking the doctor in you this only. I'm asking the human being in you this. 28 years of being a psychiatrist, what have you learned about sadness?
See, try and understand this. It's so, one, I can't not be a psychiatrist. It doesn't really work anymore, right? Like most emotions, sadness is an emotion. I'll feel sad. You'll feel sad. Imagine that when you've, at any juncture of your life, when you felt sad for a few hours, maybe for a day or two, whatever the trigger could have been, ignore that. Now imagine that level of sadness multiplied by a couple of times, 24/7, few weeks in a row, without even an apparent reason. How tough would that be? That's depression.
Is that clinical depression?
There is only one depression which is
There's
clinical.
only one depression.
If I say depression, it's a medical illness. And like I said, to almost 280 million people in the world suffer from depression. And depression is an illness. Depression is real.
Biological, thinking-based, cognition-based, and social, right? These are the
Biopsychosocial.
Biopsychosocial. Okay. We need to speak about depression because until now, I think I picked it up from one of the podcasts that there is a difference between clinical depression and other forms of depression. No, there's only one kind of depression. But lots of people again self-diagnose.
Because we use these terms. See, the problem, Ranveer, is in the language. If depression would have been called something random, or let's say something that doesn't have any meaning,
Sure.
then you wouldn't have said that word. Some mumbo jumbo. You wouldn't have used that word in your day-to-day living. That's where the problem is. And that's why I feel that using mental illnesses as slurs or even as explanation is a problem.
Fair to say that one should only use the terms related to mental illness after visiting a mental health professional and being diagnosed. Like in terms of...
after being let's say diagnosed would be the right term. I don't think everybody can possibly reach a mental health professional. I do feel that the general practitioner, the family physician level has to be the go-to. That is the solution given the deficit of experts. I don't think we have the capacity where everybody struggling with mental health can actually go to a mental health professional.
And your general practitioners, to some degree at least, can diagnose mental health.
Absolutely.
Okay.
I mean, to say that only experts can do what experts can do would mean that for every stomach problem, you'll need to go to a gastroenterologist or a gastric surgeon. How is that logical?
Okay, fair. Where is mental health related science at right now, and where is it going? Because medical science is evolving very fast now. I'm sure mental health science is also at that same point in the timeline.
So the easier way to look at this is to go back in history to understand the speed. There was virtually no medicine available before 1950s.
For mental health issues. What was the first one?
So it started with, let's say, for the treatment of schizophrenia, psychosis, initial medicines like chlorpromazine came. And if I'm not mistaken, it came in early 50s. So if I had a psychosis in 30s, there is no medicine.
Psychosis is?
So schizophrenia, for example. Why I'm saying this is, if I don't have a treatment, what will I do? That's what encouraged the non-science aspect. That's what encouraged all the other theories, which is why there have been times in history where torture was used as treatment for mentally ill. There was all the voodoo and all those things also done at that time. Why was that there? Because they didn't have any other explanation. And that's why, as I continue to say, even today millions suffer in silence. That bothers, right? Because today you have treatment. You have treatment for most illnesses with evidence. Now, any science which has had this meteoric speed, 1950s is how many years back? See it like that.
75.
Yeah, that's about it. So whatever has happened in this span in time. So obviously when initial medications came, right? So let's say sedatives when they came. So initial sedatives did not have the best side effect profile.
They had bad side effects.
Yeah, as in you'll sleep a lot more. Impact is a lot more. There is some symptom relief also happening. So gradually science evolved. So whether it is the antidepressant component, whether it is the antipsychotic component, whether it is the sedative aspect, all of them have gone their own evolution.
Okay.
And that's what is happening. So one needs to understand this aspect that things are growing, changing. What I see in the future, to be honest, I do feel AI will play a significant part in mental illnesses and mental health in years to come.
In terms of identifying mental illnesses?
Lot more, Ranveer, lot more. I feel AI will have a lot more part. I also feel that there isn't a choice but for AI to play a part.
Like, can you explain, as a psychiatrist, how will it help you?
I would like to first look at the problem and then see what all can every other component do. What is the problem? Problem is that the prevalence of mental illnesses is significantly high. Experts are not enough available to take care of the burden of mental illness currently.
And that number is just going up.
So experts' growth can only happen in a certain way. Illness is beyond our control. So if, like let's say it was the volume of the that made us realize that we needed more beds. But before we didn't realize we did not have enough beds. Even in urban cities.
So how will AI help?
Yeah. So what all can AI do? It can, let's say, become a triage. It can, let's say, screen and filter. It can, let's say, uh, even do some basic level of guidance and training. It can be used for skill upgradation. It can also be used for crisis intervention. It can also be used for distress related guidance and counseling. So, for example, let's say somebody is having a problem with sleep, and some sleep hygiene, some self help, some things can also be tried, assuming the other components of sleep, let's say an illness or something, are not there, they can be taken care. It's difficult to say in the future what all will happen, because what is happening now, if you would have asked me when I did finish my schooling in 89, that there'll be mobile phones, I would have not believed you.
Are you visualizing a bit of a robotic nurse or something, or an app to make it more relatable?
I feel that apps, AI would play a significant part. How well AI develops and whether it creates some kind of an attendance of the future also or not, again, a difficult question to answer. But I don't rule out things in life. I think, if nothing else, age teaches you humility. That just because you know a little, that is not all knowledge. There is a lot more. In fact, what I know is a droplet. What I don't know is a lot more than what I know.
How do you treat someone who has anger related issues? And maybe how do you even diagnose whether they actually need some kind of help or they just need some kind of...
No, so see, try and understand this. All emotions are experienced by all of us at different moment in time. I'll also be angry at times. You'll also be angry. We'll be sad. We'll be happy. We'll be irritable. We'll experience shame, guilt. We all do that. There's nothing wrong in experiencing normal emotions. It's the impact of that emotion which needs to be seen. So if you are getting angry in a way which is affecting your social life consistently or your work life, let's say you do what you do for a living. Now let's say that you start getting a lot angry and you start getting angry at your team. Let's say you get angry at your team in front of your guest. Let's say you are so irritated by the guest only that you give it off to them a couple of times. How would your career go? Right? So it all depends upon the impact and what you do. You could be an athlete and somebody could, trigger a little bit by sledging you a bit here and there, and you lose your wicket the next ball.
Yeah. According to me, very amateur perspective, but I think anger is one of the greatest villains in your career's journey.
Yes.
Fair?
Yes.
I think any career in the world gets negatively affected by anger.
Absolutely.
What is the process you follow as a psychiatrist when you're treating someone for so-called anger management?
So if somebody is having anger and there is no other medical, as in mental illness, then I would typically not work with that person. I would ask the person to take therapy, counseling with a psychologist. The psychologist would help this person identify if there is a pattern, which means we all have certain vulnerabilities. So let's say out of the 100 outbursts that you have, are 70 or 80 following some kind of a trigger mechanism or a pattern? Then you start helping that person understand that trigger, how to control it, so on and so forth. You parallel also help the person, you look at the frequency. So if the frequency is a lot more, then you approach it in a way. If the frequency is a lot less, then you look at the situational aspect there. And then you make people recognize this is what brings out something from me. So if this trigger is happening or is about to happen, I become more aware. I am more aware that I will not fall back into that cycle. I'll choose another option. I also learn relaxation. So when I'm feeling that arousal happening, I then use my relaxation approach. I also look at various mechanisms of de-stressing, physical activity, sports, running, gym. I mean, I'm a firm believer of sport. I hope everybody plays a sport, right? So all of that also needs to be seen. Sometimes anger may also be related to, let's say, not getting adequate sleep. It could also be related to maybe you are having a lot of frustrated experiences happening at work, which is constantly keeping you vulnerable, which makes you more angry in other situation, which means you are displacing your anger from situation A because you can do nothing there and you're bringing it out in situation B. So there are too many perspectives here. So this, like any other medical field, it's not going to be a generalized approach.
Sure.
It's a tailor-made approach based on your individual self experiences, journey, upbringing, family, friends, socio-economic, all of those factors.
Okay. What is the actual link between your mental health and occasional alcohol usage, which is actually a very relatable problem for a lot of urban listeners? Say if they drink every Saturday night, that's it. And they don't binge drink, but they have maybe like 100 ml or 120 ml. Then does it affect your
You
mental
can't
health?
have a generalized comment on that because we don't know how whose body and whose brain reacts to alcohol in what manner. You may probably have had, let's say, much lesser than that, and you may have slurred speech, you may end up misbehaving, you may end up driving and having an accident for that matter. All of that is also possible. And it may coincidentally happen that you have a lot more and nothing happened. Neither is saying that because I had a lot more, that means, oh, I am some kind of a, my body can manage this and that. Nothing to feel cool about, right? I'm very, very hesitant in any which way to sound even remotely okay with substance use, because my worry with substance is very simple. No one ever you will meet in your life, or I will meet in my life, who would say that when they had their first drink, or when they would have it only with friends and family or social, they could have ever thought that X number of years down the lane, they'll probably have to see a psychiatrist to quit it, right? You will need to quit it because you've used it.
How do you make someone quit, like as a psychiatrist?
Not the easiest thing to do. Not the easiest thing to do, because most people who would reach us have had a very, very long usage.
And probably some liver problem, and the liver doctor sent them to you.
Also, that's true. But how I see it is that it's a multiple aspects, which means initially you are looking at ensuring that the immediate withdrawal, which makes it difficult for leaving, quitting, you take care of them, largely a medical treatment. Then
The withdrawal would be like what?
So it could be anything. I mean, depending upon the substance that you've been using. So let's say if we were to take about alcohol, it could be restlessness, irritability, tremulousness. You could even have a withdrawal seizure, which is an epileptic fit.
From alcohol?
Yes, withdrawal seizures is a reality. You may have a withdrawal seizure. So you may even have alcohol delirium. Delirium tremens is the term, which means you actually go through a delirious phase because of during the withdrawal. But sleeplessness and restlessness is typically what people experience very soon. So that's why I end up taking it again. They feel that thing is gone, so they feel it's helping me or relaxing me, not realizing that it's a withdrawal which has all started. So you look at various phases, and typically family work, sometimes group work, sometimes individual therapy, all of that needs to happen, sometimes medications as well. But it depends, and some people may require to go through let's say a long stay inpatient care as well.
Rehab.
Yes, some people may require a longish stay who've had multiple attempts at quitting, and may need to go through a longish stay because your life has become so habituated that you don't know how to do without that particular substance. So giving you that safe space where in your vulnerable moment you don't get it, and you learn how to come over that vulnerability.
Good point to speak about addictive personality disorder, which is also a commonly used term nowadays.
So borderline personality disorder, narcissistic personality disorder, two of the favorite terms of social
media. We need to expand on both these. Which one would you like to do first?
You pick which you prefer.
Sir, because I'm a narcissist.
Anyone who keeps clicking their own selfies and puts them on their feed is a version of narcissism, Ranveer.
So it's actually my exes who told me I'm a narcissist.
So, which is also what most people tell each other in their relationships, but when they don't work. But try and understand this. Narcissism means me matters.
That's it. Nothing other than me matters.
Me matters. In a very simple way. So my feelings matter, yours don't. My vantage matters, yours doesn't. I matter, you matter as long as I matter to you.
Again, biopsychosocial?
Again, personality disorders need to be seen a bit different than illnesses. The biological component, we would still need a lot more time to be able to say in years to come, especially with different personality disorders.
Like science can't point out exactly what is causing this.
Not really. But certainly not. But so lots of things. And that's why the psychosocial component probably also needs to be seen a lot. But yes, we'll probably have a lot more pinpointing in the future. Right now, it's multiple aspects which we are not really aware of, because like I said, these are personality disorders which they would have started somewhere very early.
You know how we just said that biology is going to take some time to exactly point it out, but that psychosocial aspect, to some degree you're able to tell that there's a personality disorder going on.
No, you are able to tell there is a disorder because there are diagnostic criteria. You behave in a certain way, it's causing impairment of functioning. You've never realized when it started, and it's been with you for a while, and it's causing impairment, and so. Sure. So that's one part.
You'll run them through a psychological test
or a conversation, and then so that the treatment, which means the psychosocial, the talk therapy treatment in personality disorders has a lot more role than a pure biological treatment, which is using medications. Medications typically in personality disorders would be when you also end up having comorbidity of illnesses, meaning because person A has an illness and also has a personality disorder, so meds are given. But right now, to say that personality disorder, a med would be, one is absolutely certain that the med would help, not really there.
How do you so-called treat someone with a narcissistic personality disorder?
You will have to take the psychotherapy route, which means you will need to, the individual will need to be in therapy.
With a psychologist?
With a psychologist, yes.
What is your role in that as a psychiatrist?
Like I said, if there is a comorbidity component happening, which may be helped by a medication, let's say depressive illness and anxiety disorder, some other things, then probably yes, but not otherwise.
Okay.
Therapeutic intervention in personality disorder. Largely therapeutic interventions work.
And again, one should seek help when it's bothering their career performance, relationship status, and family life.
The problem with narcissistic personality disorder essentially is also going to be about not being open for treatment. Because if I am right and you are wrong, then why should I go and take treatment? So it's a tough one.
How do they even decide that, okay, I need help?
Some do, some don't.
Many don't.
Most wouldn't. Because most people who end up coming for personality disorder help are people who end up coming when they have some kind of a significant setback. And because they aren't able to deal with it, it could be anything.
Divorce.
Anything. It could be job, finance, works, relationship, something else. It could be anything. And when that happens, they feel prompted to talk to someone about it. And then it depends on how it goes.
Fair to say that narcissistic personality disorder leads to a lack of empathy towards other people?
Narcissism per se. So narcissism, which means I value my feelings and I value my thoughts and I value me, and I'm not able to have the empathy, is very much a core aspect of narcissism. Yes.
Okay. I'm assuming that people with narcissism seek help when one of their loved ones tells them that, listen, you need to go and at least check yourself?
I mean, yes and no, because sometimes you would not really listen to them, and if you're told that you need to take help, then sometimes they may not take that well as well. It also depends upon the zone, the circumstances that this individual is in at that moment.
Are they capable of loving?
I'd like to believe humankind is capable of.
Except for them.
No, I'd like to believe humankind is. Although I think we are not, I don't want to be cynical, but I don't think we are mindful enough to be able to understand the importance of meaningful relationships. Although the longest study of happiness says that the one thing that makes you happy is meaningful relationships.
Yeah. And you realize that more and more with age. You ask any old person about the meaning of life, and they'll boil it down to something related to either relationships or some kind of regret. It's one of these two things.
But relationship, how will you have them? No? How will you grow and develop a relationship? You'll need to give it time. You'll need to give it communication. You need to let go at times, and you will have to, both aspects, the compromise, the flexibility, the openness, the growth, the learning, the effort. No relationship like our work can survive the test of time without effort. Today you put an effort in doing what you do. Reduce your effort by 30% and see where will you reach.
Yeah.
So the same applies to a relationship. You reduce effort, it won't last.
Okay. Let's talk about the other one, BPD. Again, it's very, very common in cities nowadays.
So borderline personality disorder would be much common as a personality disorder as compared to other personality disorders. That would be true. And borderline personality, also known as emotionally unstable personality. This is also a term that's used. So what is happening here? What's happening here is that the emotional lability component is there, which means my emotions are very labile. So I may feel good today, bad tomorrow. In my good, I will do a lot for you. In my bad feeling about whatever I'm feeling, I might feel that you are the worst today. So my intensity of reaction is very high. The trigger may or may not matter so much as my intensity of reaction is. So I may actually end up having a lot of moods. I may also end up having a lot of reactions. I may also not able to maintain stability of my relationships. I may have easy anger outbursts. And that is a part of the borderline personality.
It's very difficult for the partners involved and the family members.
So people with personality disorders, the impact on family would be there, or the loved ones or the caregivers would be there. But I believe in it, and so I'm saying this. This applies lock, stock and barrel to most illnesses which are chronic, which means which last long enough. I don't want us to say that a person with a personality disorder is not a good person to be, not the right person to be with, and because of A, B and C. Yes, there is a whole different difficulty aspect to being with a personality disorder individual, but it could have been some other problem as well. So and it's not that it's in an individual's control.
Because I'm 31, I'm at that age where people consider that I should have been married by now. That's one aspect of being 31. Another aspect is my friends who got married in their 20s are starting to get divorced, many of them. And I've seen that in many of those cases, the word BPD has been brought up.
Overusage of mental health illness terms continues to be there because sometimes it is the most easiest externalization happening, and I don't think we can do much about it because people will continue to have fixed solutions, quick fixes, even to when it comes to explanations, and that's how it is. But to say that if you have if you've experienced 10 people who had a relationship that did not work, and half of them had someone in that, one of the partner had it. That's rubbish. That's not possible.
Biopsychosocial side of BPD. So is there a bio side?
Again, when it comes to personality disorders, to be able to pinpoint is a difficult one. But in when it comes to borderline personality, because certain correlating factors have been noticed, as in some people have more illnesses, which means they would have more proneness towards, let's say, depression, more proneness towards anxiety disorders, sometimes even illnesses like seizures are slightly more in certain borderline personality as compared to some others. So why I'm saying this is that yes, there would be a biological component, but to be able to say right now this is the biological component and give this medication to clear it out or to correct it, we aren't there. Yes, medications are used, but they are used typically based on the here and now symptom profile an individual has, which typically would be related to mood, anxiety, sleep, that aspect. But not to say that I'll give a medication and take away the personality disorder. I don't think we are there.
What medications are involved in personality disorders?
There aren't.
There aren't. So what is the treatment?
Therapy.
Okay.
You are looking at psychotherapy, and that's the only way to look at it. And like I said, medications will be used when there are other factors which typically do come.
Gotcha.
But not that personality. So if you say that person A has depression, I will say, okay, A, B, C or D medication will help, or with an 80% probability.
Right.
But I won't say that for personality disorders.
When should you seek help for what you believe to be BPD?
No, the earliest the better. I mean, what are you waiting for?
If
you are struggling with your own emotions, and if you are struggling to be happy in a consistent manner, and if you feel that you end up not sustaining relationships, or you feel very dissatisfied, and you feel that you have outbursts and swings that make you feel that stability aspect is missing, yes, you should seek help. You don't need somebody else to tell you that. You just go ahead and seek help.
While this aspect of childhood is extremely elaborate when you're speaking about adulthood mental health, is there like a common childhood experience or a very significant childhood experience which we can speak about in a generalized manner that affects a lot of adults in urban environments today?
Yes, and I think it will come down to bullying.
Bullying.
Experience of bullying in childhood can lead to significant mental health issues as adults. And in fact, the WHO report also mentioned about bullying. And I think it's very important that as a society, especially people in the field of education, understand the importance of making schools bully free.
What's happening in schools nowadays? I'm sure you get kids, I'm sure you get like parents. Has bullying reduced? Because I know for a fact that ragging has reduced. Like ragging wasn't even a thing when I was in college, you know?
Yeah, wasn't there my time as well. But how can it reduce? See it like that. Because I feel bullying in various forms has actually increased.
Cyberbullying.
Yes, because trolling and cyberbullying has taken bullying to a completely different level that we would have never imagined. When internet came and we used to have that dial-in connection at that time, way before you would have started using internet actually. So right, so I would have never thought that something like cyberbullying would happen. I would have never ever thought that people could actually experience being bullied. I mean, what is happening right now on various platforms on trolling is just unacceptable.
What does it lead to in adulthood? Like if you've been bullied as a kid?
Lots of things. I mean, let's look at basics. I mean, it can look at your self-esteem. It could affect your sense of cohesive, positive self. It could affect
What does that mean?
Meaning, I may feel inferior about myself.
Inferiority complex.
Yes, complex is again a word not really used now, but I may feel inferior about myself. My body image may be poor, my self-image may be poor. I may not be able to find comfort in relationships. I may struggle in relationships. I may not be able to be in relationships. I may not be able to trust people. My confidence may take a beating. If I'm bullied, I'm more likely to be a school dropout. If I have bullied, I'm more likely to perform academically poorly. If I'm bullied, I'm more likely to have adult problems, including depressive illnesses, anxiety disorders, sleep impairment. Depending upon the nature of bullying, I may end up having post-traumatic experiences as well. Bullying is a concern, not just for children. I do feel that the kind of I do feel that the kind of trolling that we are seeing across platforms on social media right now, we're not understanding it today. I don't know what impact it will have on the society 30, 40 years down the lane. What I can say for sure, it'll not be nice.
Unfortunately, the root problem behind bullying boils down to the parenting of the bully.
The environment of the bully, and you're right. And something that I'll compare it again with what happens on social, that people who will troll you, or people who will abuse you, or people who will cyberbully you will be much lesser in number than people who do not agree to that view, or people who actually are
in support of you.
The problem is those guys don't speak.
Yeah. And also your mind picks up on the negatives much more.
Yeah. Your mind would. I mean, how can you not? I mean, to say that you completely shut off from the chatter out there, I don't think it's possible. It's never possible. Yes, you can train yourself increasingly not to be affected by it, yet sometimes you would be. But I feel that negative communication in its continuum is not good for the psychological well-being of any society. You can't pick up your phone and open a platform and just read negative messages. Right now, that's what's happening, and that's very, very unfortunate. We aren't as bad as what we've made ourselves to be. There is goodness. We just don't see it because it doesn't speak enough.
In your view, bullying has increased all in all?
Yes.
I'm feeling bad for the teenagers and kids of today.
Yes, I think bullying has increased. It's only that it's become more in dimensions, which means what was happening only in certain spaces, in the physical space, is also happening in the online space. And what we don't understand, and let me, since a lot of people listen to what you say, try and understand this, and I'll take you into the mind of a 14-year-old. A 14-year-old goes on a platform, directly does not get any negative comment, but reads comments on the same platform on other people by other people. Now relates to this one person being abused, bullied, trolled, and relates to this person with some similarity. Now imagine. That is the negative experience we are giving young people. And people who hide behind a handle's name and it's just not cool.
Also, it may not change going forward.
Oh no, it'll become worse.
Yeah.
We'll just make it a lot worse than what we are, and without even understanding that that's as cannibalistic as it gets.
You know, unfortunately, psychologists and psychiatrists are going to be overloaded with work in the coming decades.
Yeah, and that's why you need AI.
That's why?
That's why you need AI. You'll need artificial intelligence. You will need more, because you won't have enough humans to do.
Yeah. Based on the damage that's happening today in 2024.
We don't have the number right now also. The only difference is that 75% of people are not seeking help. If all people who are struggling today were to seek help, we don't have the experts.
Yep, fair. Dr. Parikh, thank you for your time. I don't mind speaking to you for the rest of the day because I'm learning about the brain and your experiences as well. And
pleasure.
I think you've added to media literacy when it comes to all these topics. So really appreciate your presence, really appreciate the education that you've spread today. So lots of love and all the best with your journey. This was very enlightening. Thank you, sir.
Thank you.
Appreciate it.
Thank you.
That was the episode for today. Ladies and gentlemen, I'd love to know what you thought of this one, and I'd love for you to recommend more psychology and psychiatry related guests on TRS. Please Tell us what you thought of this episode in the comments below. Send in your guest recommendations as always. TRS will be back with another epic health special very, very soon. Until next time, guys, from Ranveer and the team, we'll see you later.